Good evening. Uh, Thank you, organizers, for giving me this opportunity to present a very important topic regarding the maintain basically the strategy to save the susceptibility of antibiotics. That means how to prevent the resistance of antibiotics. The in the section, the bread and butter of this to treat the sepsis, we have the antibiotics apart from food and vasopressors. So okay, we'll start. So, what's up in the sepsis strategy to save the susceptibility of antibiotics? So, from the day of introduction of antibiotics, it was predicted that someday there will resistance to all the antibiotics. So, Alexander Fleming said on his Nobel lecture that the time may come when penicillin may be bought by anyone in the shops, and then there is the danger that the ignorant man may easily underdose himself, and by exposing him to microbes to the non-lethal quantities of antibiotics will make them resistant. So these days now has reached. So now we are facing the global crisis of antibiotic resistance, and that can affect anyone at any age and of any country. And so these antibiotic resistance are leading to the difficulty in also treating simple infections. Now we are getting infections from the community acquired infections with carbapenem resistance. So the magnitude problem is huge. That in USA there are 2 million of cases of infection with MDR organisms. In Europe there are 25,000 deaths per year due to MDR organisms. In India also we are getting the MDR organisms, both MRSA and MDR GNB. But how to exactly quantify the problem, because due to logistic issues and all these things in developing country, we're not able to exactly quantify the problem. But here you can see there is growing resistance to all the antibiotics we have, and this is not now confined to the medical population. It is also now a common public health problem. So this is a small paper showing the antimicrobial resistance surveillance from India. It is was study was done in major hospitals from ICR New Delhi, AIMS New Delhi, PGI Chandigarh, CMC Bhelwar, and Jipmore. It is so that there was in gram-negative organism, the Klebsiella pneumonia was resistant to carbapenem around 50%. The Acinetobacter is resistant to carbapenem, there are 80% cases. Now also we are getting the polystyrene resistant organisms. Coming to gram-positive organisms, also we are getting the Behera organisms. So the disturbing trend is that nowadays we are very less number of antibiotics coming up, and whatever antibiotics we have, we are getting pan drug resistant organisms. So in the pipeline there are very few antibiotics nowadays to treat with the antibiotic resistant organisms. So the growing challenge is that we have MDR organisms leading to high mortality and morbidity, but there is no new antibiotics in the pipeline leading to use of the older antibiotics like colistin or fosfomycin, which were not used in previous days due to side effects or toxicity. So how does it occur? How does the antibiotic resistance occur? It occurs naturally, but when we use the antibiotics inappropriately, it leads to the accelerate the development of MDR organisms. So what happens when we use the antibiotics inappropriately, the lots of organisms or bacteria are in our body, the some of them may be not susceptible to that antibiotics, and this not susceptible or resistance and bacteria when exposed to the antibiotics lead to survival, and that multiplies and replaces the susceptible bacteria, leading to the generation of MDR organisms. So their simple bacteria lead to a super bacteria. So and now when then their MDR organism develop, that may be transmitted to one patient to another patient depending on the poor infection control system, the hospital, or lack of hygiene, poor sanitation. Also to deal with them, we do not have much of antibiotics in the pipeline. So how to handle this antibiotic resistance in our eyes? So we have to strictly follow the antibiotic stewardship program. So basically, what is antibiotic stewardship? It is basically careful and a responsible management of antibiotics. So there are few goals of antibiotic stewardship. The primary goals are to each patient must receive the most appropriate antibiotics, and there should not be any overuse, misuse or abuse of antibiotics, and that is to minimize the development of resistance. There are some principles of antibiotic therapy that to prevent the antibiotic resistance, like the antibiotic should be right selection of the antibiotics from the first time depending on the local susceptible pattern. And to start with, you must use the broad spectrum antibiotics, and then we can de-escalate or we can give the shortest duration therapy depending on the organism. To decide the right dose, we have to think of the PK/PD of the antibiotics. It is a complex interaction between the host pathogen and the antibiotics. So, in PK consideration, in case of a sepsis patient, their PK/PD is deranged due to leaky capillaries, altered protein bound, augmented renal clearance, extracorporeal circuit. These all lead to increased volume of distribution and increased clearance. So, what much amount of antibiotic we administer, that may lead to inadequate plasma concentration, so leading to treatment failure and development of antibiotic resistance. At the same time, if there is end organ dysfunction, the clearance of the drug will be decreased. That will lead to high plasma concentration and toxicity from the drug. So we have to take care of the PK pharmacokinetics consideration of the drug while dealing with these patients. Also, similarly, we have to consider the pharmacodynamics characteristics of the antibiotics, like whether the drug is a time-dependent drug or a concentration-dependent drug. Accordingly, we have to administer the drug, how much duration the drug to be given, whether a single OD dose or TD dose, or whether an infusion or single shot. So that should be decided based on the pharmacodynamics consideration. So while giving the antibiotics, we must have to careful about the PK, PD, pharmacokinetics and pharmacodynamics. Then how to choosing my optimal antibiotics? This depends on the various factors, like the host factors, PK/PD consideration, the site of infection, then the pathophysiological consideration, the invasive care procedure, the protein binding of the drug, also the drug availability, local antibiogram and cost of the therapy, also the antibiotic sensitivity report, and then I have to decide which agent will be appropriate agent for this patient. So another thing for to prevent the antibiotic resistance is TDM. This is newly coming up because in sepsis patients, there may PK/PD is deranged, so there may be underdosing or overdosing of antibiotic due to derangement in the PK/PD. That may lead to under or overdosing of the over concentration of the drugs in the plasma level. So that may lead to therapeutic failure, or that may lead to toxicity. So we can go for the therapeutic drug monitoring for optimal dosing of the antibiotics in the septic patients. So any literature, what the literature said, there is a position paper from the various societies, including the ESICM. What they said, the panel recommends the routine therapeutic drug monitoring for the various drugs like aminoglycosides, beta-lactam antibiotics, linezolid, ticaprolol, vancomycin, antifungal, voriconazole. So, after starting a optimal drug according to the PK/PD and many other factors, when to de-escalate, because if we will not de-escalate the antibiotic when not required, that will again lead to the overuse or misuse of antibiotics. Then what are the factors to consider in de-escalation? To narrow the spectrum of antimicrobial coverage depending on the clinical parameters and laboratory parameters, and to stop the antimicrobial when not required, or to de-escalate to single targeted therapy. So while de-escalating the antibiotics, it is easy to say how to de-escalate the antibiotic, but how to decide at the bedside when to de-escalate the antibiotics. This is a simple table which shows if my patient is improving, and this should be done by the day 3, because only within 48 hours we are able to get our culture reports, if routine culture reports, if not our advanced mode like multiplex or the PCR based test. By the 48 or 72 hours we will able to get the organisms. If my patient is not showing any clinical or microbiological evidence of infection, I can stop the antibiotic by day 3. And if there is some culture positivity and my patient is improving, I can give the targeted antibiotic by day 3, and my patient is improving but the microbiological report is not showing any growth, I can continue the same antibiotic. If my patient is not improving, I can either escalate the antibiotic to next broad spectrum. Then how much what the guideline says, or surviving sepsis guideline says, the daily assessment of de-escalation of antibiotics, not to any fixed dates. That should be daily assessment for de-escalation. Then how much duration? The duration, the guideline says the shortest is the best. And here the large list of paper showing the shorter duration, what maybe for a pneumonia, maybe for a bacteremia, maybe for intraabdominal infection, maybe for UTI. The shorter duration versus longer duration, there is no difference in outcome. So now coming to some concept called the low-hanging fruit concept for antimicrobial stewardship. That the fruit that grows on the lower branches usually more abundant and easier to pluck. So basically, this is selecting the most optimal targets rather than confronting with the more complicated management targets. So these are the strategy of low-hanging fruits in antibiotic stewardship is the intravenous to oral conversion, like the drugs having the voriconazole, linezolid, proconazole, in which the oral is equally effective for like IV, so cost will be reduced, and batching of intravenous antimicrobials according the dosing, and therapeutic substitution and formulary restriction for the restricted antibiotics. Then what is the missing link between this? The missing link is the in this antibiotic stewardship program is the over-the-counter drug availability. As per the WHO, about 50% of the antibiotic prescription worldwide are inappropriate, and two-thirds of the antibiotic accessible at the pharmacy are being used for self-medication. So stewardship program should be tightly used in all the ICUs and all the hospitals. These are the various components of the antibiotic stewardship program. So we have also a national program for antimicrobial resistant containment by Government of India, and also while you taking care of all these things, the proper antibiotic stewardship, we should not forget the basic things like hand hygiene and barrier precaution. Because while the one patient developed antibiotic resistance, their patient the infection from MDR organism from their patient travels to or infect the second patient or next patient by the, mostly through the healthcare workers. So the hand hygiene and barrier precautions should be taken care properly. Then there are some environmental cleaning should be done properly. There are various studies which show the environmental cleaning and environmental care leads to decrease MDR infections. Also, topical decolonization is there for to reduce the antimicrobial, decrease the antimicrobial resistance. Some studies, because the staph aureus, which is the most common colonization in human skin, that lead to MDR or MRSA. So, if we can eradicate this colonization, we can decrease the MRSA. So, apart from that, what are the other future trends? Apart from the antibiotics, or best use of antibiotics, what else we have? We have vaccines, we have bacteriophages, we have antibodies, and also we have microbiota and diagnostic advanced diagnostic tools for early diagnosis. So we have also some advanced material like antibiofilm surfaces of silver and titanium oxide nanofilms, the antibacterial enzymes and peptides, cationic polymers, and also advanced nanostructured materials. These are all in pipelines. There is no robust evidence for the use of them, but these are all in pipelines. So to conclude, the antimicrobial resistance is rising and is a real concern. So to prevent it, you have to, for what the evidence we have, you have to use the antibiotic properly with proper implementation of antibiotic stewardship program. But at the same time, we must not forget about the basics like hand hygiene and environmental cleaning. Also, we should go for the early diagnosis by the PCR-based test or detection of antimicrobial resistance and new antibiotics development, and also we should focus on the development of new antibiotics and for future trends, other methods. So to summarize, to prevent the antibiotic resistance or to maintain the susceptibility of antibiotics, we have to attack this from various fronts. From the antibiotics, the national policy and AMR committee or standard treatment guidelines, then immunization, the PKPD, we have to take care of the PKPD of the drugs, therapeutic drug monitoring. So all these things we have to concentrate to take care of or to prevent the antibiotic resistance. So to summarize, these are the factors like factors in the hospital, factors in the community, and factors in the non-human use of antibiotics. About 60 to 70% of antibiotics are used for the non-human use or agriculture or for animal husbandry. So these factors all lead to antimicrobial resistance. So all the steps in the hospital, steps in the community, and the national and international commitment must be there to prevent the antibiotic resistance to save our future. Thank you. I've come.
Thank you, Dr. Srikant, to speak on how to save the antibiotics for the future and reduce the antimicrobial resistance. We'll go on to the next talk. We'll take up the questions in the end.